Good evening, ladies and gentlemen, dear colleagues. It's a great pleasure and honor to be here, part of this remarkable conference here in Egypt. I want to thank the organizing committee personally and on behalf of Croatian Society of Neuroradiology, of Croatian Medical Association for opportunity to be a speaker at that conference. Let's go back to brain. When you analyze the brain, we usually start with sagittal T1. But first of all, maybe some few words about midline anatomy. We have many important structures there. So when we analyze, we start with brain with supratentorial and infratentorial part, but many different smaller structures as pituitary gland, mammillary body, optic chiasm, hypothalamus, epithalamus. Then we analyze thalamus, midbrain pons, posterior commissure, anterior commissure, etc. On the normal sagittal midline, we could see central venous vascular and cistern as great cerebral vein of Galen, internal cerebral vein, thalamostriate vein, and many different cisterns. So we can also see the continuity of the CSF flow channels as intraventricular foramen of Monroe, or Magen D, or Sylviev aqueduct, etc. And also we can see some of the major contour of the brainstem and the encephalon, like body of the fornix, lamina terminalis, tegmentum of midbrain, tectum of the midbrain. In our hospital, University Hospital Center, we use this MRI protocol. We start with T1, sagittal, then T2, flare, axial gradient, DVI, ADC, and enhanced T1. I would like to show some examples from our clinical practice. Viewing the sagittal T1 midline is a good approach starting point. This is the example, female, 15 years old, with Chiari-1 malformation is the most common type of the cerebral tonsil, more than 5 millimeters below McRae line. We could see also mismatch between the size and content of the posterior fossa. Then we can see crowded foramen magnum as well, vertically oriented cerebral sulci, brainstem compression, etc. Second example is female, 52 years old, with syringomyelia and syringobulbia. As I suppose so, of course you know, and you met in your daily practice many times syrinx, but not so many times syringobulbia, which is a fluid-filled cavity involved this brainstem, special medulla oblongata. If we see syrinx in pons, we call it syringopontia, then in midbrain syringomesencephaly or cerebrum syringocephaly. This is one example from our hospital. Then we have also young female with Dandy-Walker malformation. As you can see, this is most common posterior fossa malformation. On the T1 sagittal, you can see almost everything. This is the first imaging, and on one slice you can recognize hypoplasia of the vermis, encephal rotation of vermian remnant. Then you can see cystic dilatation of the fourth vertical extending posteriorly. Then you can see anterior lateral displaced cerebellar hemisphere with a normal size and morphology in large posterior fossa. Another example, I'm quite sure you have seen that, corpus callosum agenesis. It's a 1-year-old male, widely spaced parallel lateral ventricles. We call it racing car sign. Then we can see mouse head sign. We call it colpocephaly. Then you can see also a very nicely high riding third ventricle appears to communicate with the interhemispheric cistern. Then you see hypoplastic hippocampi and inverted cingulate gyrus. This genesis of corpus callosum with porencephalic cyst, when we have partial this genesis, sometimes actually we can meet also arachnoidal cyst or porencephalic cyst, like in this case. Then another example, cavum vale interpositus cyst. You can see on the sagittal T1 and T2 triangular shaped dilatation of the normal cistern of the velum interpositum, below the splenium of the corpus callosum and the column of the fornix, above the internal cerebral veins, behind foramen of Monro. In case larger than 1 centimeter in axial transfer measurement with outwardly buffed margins and positive mass effect. Some other cysts, colloid cyst of the third ventricle, female 48 on sagittal T1 and T1 post-enhanced T1. You can see easily, usually asymptomatic, but it can cause obstructive hydrocephalus. It's usually unilocular, and anterior superior portion of the third ventricle, it's in 99% located at the foramen Monro. Another example, very common, pineal gland cyst. You know that follow-up is important because some of the others pathology can look like pineal cyst if they have a cystic part. For example, pineocytoma or metastasis or germ cell tumors. So it's mandatory to do follow-up that and detect stability over time. Another case, sagittal T1 with suprasellar arteriovenous malformation. It's you can see feeding arteries, Snyder's drain vein, no mass effect, and you have seen so many things about that earlier in presentation. In this session, then we have cerebral venous thrombosis. It's easy to recognize when we have subacute phase. On the T1, we can see hyper-intense deep cerebral veins on T1. It means that it's methemoglobin and means subacute clot. Thalamic abscess, of course, we have clinical information as well. On the DVI, we can see true restricted diffusion, and we can see on the T1 enhanced T1 peripheral ring enhancement of uniform thickness. Intracranial hypotension is another example. We can see on the T1 also a sign of reduced CSF and increased venous blood volume. Also, you can see on the T1 sagittal reduced mammaropontin distance, which is also important. One case which is not so common, but we have to think about that, with interesting clinical offers, pituitary apoplexy. It's enlargement of the pituitary gland with or without bleeding. On T1 we can see a huge intrasuprasellar mass. Then we can see also peripheral enhancement around non-enhancing infarcted centra. Pituitoma, it's a rare but benign tumor. It's a low-grade glial neoplasm of the neurohypophysis or infundibulum, and you can see T1 and T2 post-contrast. It's easily to see solid mass and absence of the posterior broad spot on the T1 weighted image. Microprolactinoma I will escape. Then we have sometimes very huge process, but it's adenoma. Even you can see not only intracellular mass, you can see spread into the paranasal sinuses, nasal cavity, compression to the third ventricle, optic chiasm, hypothalamus, etc. Or craniopharyngioma. On the T1 sagittal, you can see a suprasellar mass with solid and cystic components, different signal intensity due to cyst contents, and on the CT, you can see typically calcification. Some other example, benign situation, hamartoma, and its characteristic no contrast enhancement, comparing with astrocytoma, pilocytic hypothalamic astrocytoma. It's not always possible to differentiate from craniopharyngoma, but it's quite different, and you can see a solid and significant contrast enhancement. This is one example of esthesioneuroblastoma. It became basal layer of the olfactory epithelium of the nasal cavity, and you can see spread through the cribriform plate into the interior cranial fossa. Or this example, which is rare benign but locally aggressive, highly vascular tumor, we call it nasopharyngeal juvenile angiofibroma, exclusively in young men and centered on the sphenopalatine foramen. This is one example which is adenocystic carcinoma of the nasal cavity, and we know that it's very common perineural spread, and the same situation spread to the cribriform plate, to the anterior cranial fossa, and some few examples, multiple meningiomas, sometimes seen outside the neurofibromatosis too. This is T1 and T2 post-contrast. We can see solid and homogeneous enhancement. One case of glioblastoma of the corpus callosum, and last one, it's a posterior fossa astrocytoma, which is after operation, and we can see tumor progression and compression to the brainstem, anteriorly compression to thalamus and corpus callosum. And for the end, I want to thank you for your attention and say that the sagittal midline of the brain is one of the most important sectional planes in neuroimaging. So please stop when you look at your MRI imaging, because you can see what you can find on only one slice, actually, T1 and midline. And of course, good working knowledge of the neuroanatomy of the sagittal midline is essential. And this is my hospital, the oldest one and second biggest one, and we are very proud because our neuroradiology is the only referral center of Croatian Ministry of Health, and I have been managing European Union project on MRI education worth €4 million. And this is my team and my country. And today was a very nice day, and I hope you enjoy all your lectures. We had a beautiful trip before this lecture, and thank you for your attention.
Thank you very much, Professor Dijana. You are always most welcome here in Egypt. Now we conclude